The broadcast is now starting. All attendees are in.
Shh.
Hello, everyone. This is Mark Lynn from Healthcare Business Specialist in Chattanooga, Tennessee. And this is the preparing for the RHC Certification Inspection dated June 11th, 2019. Here is my contact information if you need to get a hold of me during this session. And Danny Gilbert is on the line with us as well. And Danny, you have anything you want to say before we get started? Nothing exciting going on in your life at all?
No.
Not really. Okay. Okay. All right, Danny. We will leave it at that. But just don't expect Danny to be around for the next 2 months or so. She'll have more important things to do. So congratulations. And we will just move on from there. If you would like to join the Rural Health Clinic information group, this is a place where you're going to find a lot of information, a lot of consultants post stuff on there. You can ask questions. You can get answers for anything. We post a lot of information about different seminars and webinars that are going on, not just our information, but everybody's information. So we highly recommend that you go there. Here's what it will look like if you have any questions. It is a closed group. There's about 700 and something members as of right now. So please join that group, and that'll be very beneficial to you, I think. What Healthcare Business Specialist does is we prepare about 150 cost reports every year. I just took my little list there. We've got 137 of them done through May 31st of this year. So we'll have a few more that will slowly come in. But we're very thankful that cost report season is over, and we can move on to doing things like annual valuations. If you've not done your annual valuation, that is one of the things that does get written up as one of the 9 condition level deficiencies that a lot of people don't do. And in the summer, we tend to go out and do a lot of those. Of course, startups, where if you guys, we've been working on your startup, and we got a little bit behind because of cost report season, we're working back on those again as well. And then we do about 12 of the quarterly TennCare reports that get additional money for RHCs in Tennessee. So if you're having problems with those, let us know. Danny does a great job on those, and is highly recommended by the state, by everybody, to do the quarterly reports for them, because she seems to know those regulations better than anybody. Disclaimer, this is being recorded. We will post this on the our YouTube channel, so you can go there and see that in the future if you want to, if there's something you want to refer back to. The information is current as of today. We did post everything over in the handout section there. Apparently some of you guys are having a hard time getting those to download. That's okay. Don't worry about that. We will email those out once the seminar is over. We'll just send out an email to everybody, and we will attach these files to them so that you can have the documents that are over there. This is a free webinar, although we do have to pay for it some way, and one way we do that is by having people sponsor it. One of our sponsors is Chronic Disease Solutions, LLC, and they do chronic care management. If you've not been doing that, that is a great way to increase your revenue. Medicare has recently increased the reimbursement rate for RHCs. It's now up to $67.03 for 20 minutes of time. So it is something that is profitable for RHCs. So you may want to look into that, call Nicole, and there's her phone number, her email address, and that would be something very, very attractive to you guys. And then if you're not in a HPSA, or if you want to move and you cannot move, Joe Lampard is with HPSA Acuum out of Jamestown, New York. And those guys, we've been partners with them for many years, and they do absolutely fantastic work on getting areas back. We've had 2 clinics that we were about to become a rural health clinic, and they lost their HPSA status. And Joe was able to get it back for them in both cases there. So they've done a wonderful job for us. Today's session probably should last about maybe 45 minutes or so. We're just going to talk about the state surveys, Quad A surveys, and the compliance team surveys, and getting you guys ready for those. There's 2 types of surveys. There's going to be an initial survey that when you're going to have when you become a rural health clinic, and you will have a recertification survey depending on who you use. If you use Quad A or the compliance team, you'll have one of these every 3 years. You'll have a resurvey. If you use the state, all states are different. And so typical range is about 5 to 6. I was in Kentucky last week, and they said the state will come out once every 7 years in Kentucky. So most states, you really should prepare to have one of these resurveys, and they're surprise inspections. All these surveys are surprise. Even the initial one is a surprise survey. Expect those about once every 5 years is what you sort of want to gear towards being prepared for them. Obviously, you want to be prepared for them at all times, but knowing human nature, we tend to prepare more. When we know the test is coming, we tend to get a little bit more prepared for it than we know. Oh, it's 5 years off. We can coast a little bit till 5 years comes. That's human nature. So I'm not going to fight human nature with you guys. So timeline to become a rural health clinic. We're at this stage right here where we've already completed the 855A if you guys are new startups. And then there's the stage here where we're preparing for the RHC inspection. So that's really what we're going to talk about today. About the sort of coup de grace, the final step will be the state will come in and actually do the inspection here. So we'll talk about this process as we're preparing for the state inspections or Quad A or the compliance team. There's some certain things here that we need to do. One is we need a RHC policy procedure manual. If you're one of our clients and we're helping you with the startup, you'll send us that questionnaire, and either myself or Danny will put together a RHC policy procedure manual for you. We will put together several manuals for you as well as far as policy procedures, because a lot of you guys, especially the independent RHCs, you may not have a HIPAA policy procedure manual. You may not have a OSHA policy procedure manual, or you may not have a laboratory policy procedure manual. So we have all those manuals. We will send those out to you so that you can have those. Now you're going to have to review those and make sure that's what you guys do. So if there's something in there that you're not doing, or if you do it differently, you're going to have to modify those manuals to meet those standards. But you do need to have those types of policy procedure manuals for the inspector when they come. So and then once you get these policy procedure manuals, make sure that you sign off on those. You know, there's always this concept of RUA, review, update, and approve. Every year you have to do that with these manuals, and there will be a cover page on them that has the people that need to review, update, and approve. Typically, those people will be the medical director, one of your nurse practitioners, typically your most senior nurse practitioner, or the one that you tend to do management with, that person will sign off on them. Your office manager is not a required person, but it's typically one person that will sign off on them. And then a community representative. And that community representative is typically, it has to be somebody who's not employed by the clinic. And it can be maybe the spouse of the medical director or the owner of the clinic, or it could be the mayor. I think we thought somebody who's going to get the mayor to do that. A lot of times it can be maybe a home health person or a pharmacy person or somebody at the hospital that you work with. But their responsibility is going to be to sign off on the RHC Policy and Procedure Manual, your Emergency Preparedness Policy and Procedure Manual, and sit through an annual evaluation meeting each year. And that's basically it. Not a whole lot involved in that. We will prepare the Emergency Preparedness Policy and Procedure Manual for you guys. And if you don't have access to drills quick enough, we will go ahead and do a tabletop webinar where we'll get a tornado drill done for you, and then we'll teach you how to do a facility-specific drill, which will be the Great Shakeout Earthquake Drill, which are very simple to do. That will get us our 2 drills that are required each year to become a rural health clinic, and so that's the way we'll take care of those. And in the future, what you'll do is get with your EMA director locally and get on their inspection schedule or their drill schedule so that you can participate in the drills with them. Then we will come out and do a mock inspection. We will pretend like we're state inspectors or quad A inspectors or compliance team inspectors and go through with you guys in educational sessions. A lot of people are worried, like, well, Mark, I'm not ready for this, and we don't expect you to be ready. We don't, and we're not. It's not going to be a punitive type of mock inspection. It's going to be an educational type of inspection where we have about a 20-page mock inspection report, and mainly about 14 of the pages will be stuff we'll go through with you, just basically checking boxes to make sure that you're doing what is required. And there's about 6 pages that are a walkthrough of the clinic where we'll go through and we'll look at your laboratory, we'll look in your exam rooms, we'll look at how you're storing medications and those sort of things to make sure that we don't see something that the state inspectors would not like. And then what you're going to do, we want you to prepare what's called an evidence binder. The state, when they walk in, they're going to give you guys a listing of things that they want. In most states, we already have that listing of things that they want. And we want you to go ahead and copy that stuff for that state inspector so that you can just hand it right back to them, and you can take them and put them in a nice room and get them away from the clients, get them away from people that are sick, and have them look through all those manuals that have been provided for them. So the evidence binder will help you 100% to pass this inspection very easily, because what will happen is your inspector will have copies of everything that they can actually take with them. So if they're running out of time, it will cut down the amount of time that they are at your location, and the less time they are, the less time they have to find things. And then we will have to notify the state that we are ready for the inspection. So you want to let us know that you're ready for the inspection as soon as possible, because depending on the state you're in, sometimes the states are very, very fast. Sometimes they're very, very slow in getting state inspectors out there. I mean, that is one of the advantages of using Quad A or the compliance team, is you pretty much know you're going to get your inspection within 2 months if you use them. The disadvantage is you have to pay them to come out and do the inspections, versus the state will do them for free. You just don't know how long it will take to get them to come out to do that. The inspection will there's what's old saying, begin with the end in mind. So we'll go through the end is as far as the RHC inspection goes. When you're getting ready for it, think about just child-proofing your home. Think about if you have small children, what would you do to keep your your children safe in your house. Same concepts apply, plug protectors, making sure your sharps are secured and up high away from little fingers. Make sure that your trash cans are covered so kids can't get their hands in it. If there is hazardous waste in there, put the little stickers on there, make sure that they're covered so that the kids can't get their hands in there. And then think about privacy and HIPAA for your patients as well when you're getting your place ready. As you don't want to be calling out people's weights and what's wrong with them in the middle of your hallway. So here are the three different entities that can survey you. There's two deeming authorities that CMS has approved. That's Quad A and the compliance team. And then most states will actually come out and do an inspection for you as well. Although there are more and more of them now that will not do the inspections. They say you have to hire somebody. Arkansas is that way. Ohio is that way. Indiana is that way now. More and more of the states are doing that. So keep that in mind. And then this is a document here. I think this is one that Kate Hill did for preparing for an RHC survey. And you'll see a lot of Kate's slides in here. I copied and pasted a lot of her pictures. She's got a lot of pictures. And I was at a session with Kate last week in Kentucky. So she's doing great. And we had a very good conversation. We have very lively conversations when I get in there with her about these inspections. And I learn a lot. So I always recommend listen to Kate's presentations. Survey is the key to the inspection. The surveyor is the key to the inspection. If you treat them roughly, you are gonna get the Wicked Witch of the West, and she will be able to write. I think we had one in Alabama the other day where they had almost 50, I think it's over 50 pages of deficiency. So you have to be very careful. But if you treat them right, you may go into the good witch here, and a lot of times they will tell you, well, you need to fix this. You need to fix this. And whenever that surveyor does show up, call either myself or Danny. And a lot of things that they ask for, if you don't really readily know where it is, we can tell you where it is in your documents or your procedure manuals, or if you can't readily find it very quickly, we can tend to produce something for you or find that file on our computer. We have everything's in Dropbox, so we can find it just about anywhere we are. We'll be able to find what you are. I think I've been doing. One time I was doing a seminar in Savannah, Georgia, and somebody called and said the state inspector needed this form. And I stopped the seminar and said, y'all give me 5 minutes here. I got to send something to a client. And sure enough, we sent it to them and we passed with flying colors. So first thing you want to do is prepare for the state inspector or the inspector when they come to your clinic, is make sure the receptionist knows that somebody like this is going to be coming, and treat them with a lot of respect, and don't leave them in the sick room with a bunch of kids that are sneezing and coughing and throwing up on them. That's the worst thing you can do. You're going to get a bad inspection if that happens. So you want to make sure you move them away from that area as quickly as possible. Make sure they have a good place to work, and close the door so they don't really hear a whole lot of what's going on out there in the hallways, and provide them with those policy and procedure manuals and those evidence binders, and that's going to go a long ways. And of course, call Danny or myself as soon as they're there to let us know, so we can sort of put you on high alert and high priority for any phone calls that come in. They will hand you a document, something like this. This is what Quad A will hand you whenever they get there. The state of Tennessee has a different form. I know Alabama has a long form as well. So each state will have a different form, and depending on which state you're in, we will give you a listing of the information that they're going to ask for. The surveyor will basically want to meet with you guys and sort of go over what will happen during the survey. Typical surveys, I've seen them last as little as 45 minutes or as long as 2 days. And where you really run into problems is if you see 2 surveyors, that means that one surveyor is training the other surveyor. You will tend to get written up a lot during those types of things. So cross your fingers and hope you only get one one surveyor when they come in. So what they're going to do is basically do a tour of the facility. You probably you need some type of code that Elvis is in the building or something, that a surveyor's there, so everybody sort of knows to be on high alert. I mean, obviously, we try to do everything perfectly all the time. It's just we're not perfect, and so you want to have that Elvis in the building code so that people will know to make sure to lock the drug, the sample drugs. I say a lot of people leave that door open because they're in and out of it all day long. You want to make sure you keep that door locked at all times, especially when the surveyor's there. You especially want to make sure you're doing your hand washing correct during that. I know you're supposed to do it all the time, but we've had a lot of people get written up for hand washing because now there will be an RN on the survey team, and that RN will go in to a room with you while you're seeing patients. So that happens. Since that started happening, the hand washing has been a big issue with a lot of providers not doing it properly. So they'll basically go through interview with staff and providers. That's one reason why you need to educate everybody and make sure that they've taken tests for competency and make sure that they've done some tests for the review of these policies and procedures so they know what's in them. And then let's see here. Here's some of the things that they will do. Typically, what will happen is, of course, your people should know the hows and the whys of any processes that you're doing. But if they don't know, it's perfectly acceptable for them to say, I would consult the policy because I'm just not sure. That's a perfectly acceptable answer. An unacceptable answer is, and this is when you're going to get 50 pages of deficiencies as well. I don't know, and I don't care. And I mean, they will quote you on if somebody gives them a little smart aleck answer like that. I've seen on the one that had 50 pages, we had another clinic that's owned by the same people where they had 47 pages, and they got a lot of little smart aleck answers from the nurses or whoever was asking. Sure enough, they got written up a lot. So if you don't know the answer, don't make up some answer that just say, well, I'm not sure, but let me consult policy. That's perfectly acceptable for you guys to do that. Let's see here. One of the things that we also do is put visual reminders everywhere for things to do. And I see a lot of clinics where they have little reminders of, multi-dose vials. Make sure you date, and they're only good for 28 days. And put little reminders everywhere, and that will help you to get through the survey and make sure that you do these things on a daily basis. So what the inspectors are looking for is there's 9 conditions of participation as a rural health clinic. And what we're doing is proving to them that we meet those 9 conditions of participation. This document here is the Quad A standards. There's about 60 pages of Quad A standards there. So if you want to click on that whenever you get a chance, that'll take you straight to the Quad A standards. Here is the law, the statute here. You can find the statute at law.cornell.edu, and here are the 9 sections that you have to meet. And really, the things that you must comply with federal and state and local laws. That's pretty basic. One of the things that you have to do there is all the signage that says that you meet minimum wage. You're going to do OSHA. You do need to get an updated set of those laws, and you need a 2009 version of them. If the old version of them, they could, in theory, write you up. Now, I've never seen anybody get written up for having older versions of those, but Kate said that the other day in the meeting, just the other day in Kentucky. So I'll take her word for it. Must meet the location requirements. That's basically to being a non-urban area that's medically underserved, and we'll check that for you before things get started. Physical plant and environment. Basically, you need to have a safe physical plant environment. You must do drills like fire drills, tornado drills, evacuation drills. You have to do preventive maintenance on any equipment that you have, especially equipment that's touching patients or has anything to do with patients. That has to be done within 1 year. Yeah, every year you have to do that. Organizational structure, you basically have to have a medical director at your clinic. Staffing and staff responsibilities, your nurse practitioner or PA must be there at least 50% of the time that the clinic is open. And what the surveyors are going to ask for is a calendar for the last couple months. And you need to show how much time the nurse practitioners or the PAs were there, and your medical director have a calendar for them. So if they're physically on site any amount of time, you want to document that amount of time that they were physically on site. Provision of services, you must be 51% primary care. And one of the issues we run into in Kentucky, where there's a lot of opioids up there, and the state considers opioid, if you're treating opioids, to be a mental health service. And we've had them try to take away RHCs RHC status because they were treating 51 or 55% opioid patients. So that's something, especially if you're in Kentucky, you want to be careful about those percentages. And we have a argument that if you're coding a 99213 for Suboxone or whatever, we're really not doing, we're doing medical management. We're not doing mental health services at that point. We're doing medication management. So we've argued with them a little bit about that, and we've made some headway on that argument with them. But just keep that in mind. That's the 51% rule. Patient health records, we all know about HIPAA, and so we all been doing that. One thing that they have been writing up people for a lot is consent to treat. You have to have a signed consent to treat that's been updated within the last year. And what happens is the inspectors will typically review 20 charts, and they'll go in and look at 20 charts. And if they find one or two of those consent to treats not up to date, they will write you up every single time. Another condition level deficiency that they write up all the time is program evaluation. Every year you have to have a annual meeting, and you have to have this report written that goes over the utilization of services. You have to look at active and closed charts, and you have to put together this nice little report and submit it to the professional advisory committee. Has to be signed off and placed in your policy and procedure manual. And like I said, that's done annually. A lot of people do it once and then forget to do it. Same thing with emergency preparedness. This started on 11/15/2017, where we had all these emergency preparedness rules, and we spent all this money and we did all this stuff to get ready for emergency preparedness, and we did a great job. The problem is that now that was over 1 year ago. And the state inspectors and Kate Hills was at her presentation the other day was telling me that they have written up 5 clinics over the last few months because, yes, they did everything perfectly at the beginning, but they haven't followed up with it. So remember, you have to do this stuff every year. So you do a risk assessment every year. You do training every year. You have to do 2 exercises every year. And so that is quite a burden. And hopefully President Trump will eliminate a lot of that burden by restructuring some of the regulations. But as of right now, nothing has changed. You still have to do all of that work as well. So here we go, preparing for the RHC inspection. First thing you want to do is put together your policy procedure manuals, emergency preparedness, all these manuals. You want to make sure that we have a lot of poundage for these guys when they come in. And then you need to start acting like a rural health clinic, because what will happen is the state inspectors, if you don't have these documents and forms already started and implemented, they're not going to have anything to review, and you're going to have a tougher time passing that. So about 2 months before the inspection, we want you to start implementing all the forms that we will provide for you. And we'll show you what some of these forms look like as we go through this session. One of your big jobs, again, will be preparing this evidence binder for the inspector. So that's going to be one of the key things, is to have all these documents. The inspection will go so much better if you've got this list and you do this ahead of time, so you're not running around struggling to find all these documents and trying to figure out where you put those, do it ahead of time, and it will go so much easier for you. And then, of course, do the mock inspection, do your annual evaluation. Even if you've not been a rural health clinic in the past, you have, if you've been operational for 1 year or more, you have to do this annual evaluation report. So if you're in that shape, we will put together an annual evaluation report when we do the mock inspection for you. And when we do the mock inspection, we'll write that up as an annual evaluation and then get you guys to meet and sign off on that as well. And then, of course, the 2 emergency drills, we'll have to get that done. What we did was we have something called a RHC booklet, and we will send that little booklet to you because it's got all the forms and all the things that each person should be doing to get ready for this inspection. So your medical director, basically they have to review and sign the policy procedure manual and the annual evaluation. Right now we're asking them to review at least 15 charts each quarter. It says for each nurse practitioner or PA. Really, when I was talking to Kate, she was like, if you did 15 charts every quarter, that should be more than enough. So just keep that in mind. Make sure that you sign and date those, and make sure you share that with the nurse practitioner or PA, and that they sign off on that as well. Also, you want to sign and review your collaborative agreement with your nurse practitioner or PA, and include that in your evidence binder and your policy procedure manual. Again, they're going to have to review and sign the emergency preparedness policy procedure manual. And if they can participate in the drills, that would be awesome. Now, we can't really get them always there, but that's important. Also, the medical director should help determine what emergency drugs should be in the emergency kit. And if you can document what is needed there, that will go a long way. And the compliance on the emergency kit is all over the place. So we'll talk about that in a minute. Nurse practitioners, they basically have to do the same thing: sign off on the procedure manual, annual evaluation, collaborative agreement, review and sign the emergency preparedness manual, participate in the drills. Here's the key one there, is keep a schedule on the nurse practitioners and PAs for review by the surveyors. And the reason why you're doing this is that 50% rule. They have to be there 50% of the time the clinic is open. And then, of course, they can determine what emergency drugs they feel comfortable with as well. So really, the medical director and the nurse practitioner or the PA should go over what emergency drugs you should have. Try to limit it as little as possible, because you're basically just going to throw the things away, because it's very rare that you have anybody use any of those. But you want to make sure that it's something that the nurse practitioner will feel competent in using. There's no sense in having something there that you will never use because you don't feel competent in using that particular drug. Nursing and medical assistants, this is where a lot of the work will go to, is we have certain checklists to go through, especially on cleaning, infection control. You want to make sure that those infection control items are done really between each patient. I mean, you can't have a checklist between each patient, otherwise you'd just be doing checklists. But infection control is extremely important, so you want to make sure that you're doing that. Make sure that you clean up the clinic and get rid of all the junk that's been in there forever. If you're not using some type of piece of equipment, but they're like me and will never throw anything away, then you just want to put a little sticker on it that says "no longer in use" or something like that, so you don't have to do maintenance on it. Just put that it's being stored there. Remove the clutter. I would get rid of just anything, because just about everything has an expiration date on it. So you want to look for, gloves, hydrogen peroxide, all those things that are in your clinic. Look through everything and get rid of anything with an expiration date that has expired or you think will expire within the next couple months. Make sure that everyone goes through their OSHA training, bloodborne pathogens, airborne pathogens, emergency preparedness. We have a little test for emergency preparedness, and we're working on some other tests for people as well. So we'll get those out to you as well. Make sure that you can do the required lab tests, and make sure that you're documenting the controls that you guys have. I know a lot of people say, well, we're CLIA waived, you don't have to do anything on laboratory. I've gotten that argument several times, and it's like, no. Even though these are CLIA waived tests, you still have to do controls. You still have to make sure that these kits are working correctly. And then look at your patient exam rooms when you do the walkthrough and make sure that there's nothing hazardous in those as well. Office managers, you're going to be mainly responsible for putting together this evidence binder for the state. You will work closely with us or your consultant on putting together these policy procedure manuals. You'll work with us on getting this emergency preparedness work completed. We do lots of webinars for these. Sometimes it's hard to schedule because we have so many. We try to do them at lunchtime. And because we need to get everybody involved in this. We need your nurse practitioners, your medical directors, all of your employees need to be trained in this emergency preparedness. So we try to do 1 hour tabletops during your lunchtime so that you guys can participate in those. Typically, you need to call a biomedical company to get preventive maintenance of your patient equipment, and then they will send you a detailed inventory of what they looked at, and it will have serial numbers on it. It will have dates when they're supposed to come back and do it again. You want to make sure you hang on to that and present that to the state inspector or the QuadA or compliance team inspector. And then make sure all your credentialing for your providers is caught up. Make sure you have all your licenses updated. Those are things you're going to copy and put in your evidence binder. Make sure your CPR is up to date, your basic life support as well. Those things need to be updated, and make sure you give that to them. And here's the RUA aspect of it, the review, update, and approve. So you're going to, again, you're going to have to conduct annual evaluations. If you want to hire us to do it, we'll be glad to do it. Or there's plenty of great consultants out there that do annual evaluations as well. Nothing you have to hire. You don't have to hire an expensive consultant to do it. You can do that yourself, but just remember to do that. Remember, again, review, update, and approve everything. Arrange and prepare for cost report preparation. We have about 2 or 3 that still haven't got theirs done. Medicare is going to cut your money off if you don't get your cost reports done. So keep that in mind. And then, so those are some of the things you need to do annually for that. Let's see here. Okay, 3:06. I'm looking at my time there. So we've gone 40 minutes here. Hopefully we'll get through all of this. I'll probably cut it off at about 45 minutes or so. Try to leave a little time for questions if you have those. And if you want to ask questions at the end, there's a place over here for you to raise your hand and we'll open up the line for you to talk. Or if you want to type in the questions pane here, I'll get Danny to read those questions for me and we will try to answer those for you as well. Here is what the evidence binder will look like. We typically have just a table of contents for them, and then we'll go through and put the information out for them in order for them to make it very easy for them to find what they need. So the evidence binder, what you'll want to do too is make 1 copy of it for the inspector, and then keep 1 copy of it for you, and then keep that updated at all times. And in that way, when the inspector does show up, you'll be able to hand them that file, and like I said, it'll make it much easier. So some of the things, like I said, schedules for your nurse practitioners and PAs, that's going to be very important that you have that. The rest of the stuff here, I think we've talked about. Fire department, I always forget about the fire department. You do need to call the fire department and get them to come out and do a fire inspection for you on an annual basis, and make sure to put that document in your policy procedure manual as well. Keep this little table here is one from Kate, and what you want to do is keep up with all of your licensed personnel, your physicians, nurse practitioners, PAs, nurses, RNs, medical assistants, anybody that has a license. You want to keep up the schedule and make sure that you re-credential and keep those certifications up to date. You also need to, there's an Office Inspector General. There's a website where you need to go to make sure that Mark Lynn is not excluded from the Medicare program. I did something horrible, and Medicare will not let me be in the Medicare program. You need to check everybody. You go in there and type everybody's name in there and print those off for the inspectors, because that is one thing that they will look at for them. Here's some of the things from OSHA requirements for healthcare. Some of the websites that you can go to. If you're in Alabama, they will actually, University of Alabama will actually come out and do an OSHA inspection for you for free. So that's a great thing. And I'm sure most states have something like that. And then here's just the OSHA regulations on bloodborne pathogens for you guys. Here's some of the ideas on how to safely store your vaccines. And a lot of people are using single-dose vials now instead of the multi-dose vials. But we're going to run out of time here, so I'm going to go through these pretty quick. Here's some of the reminders. Remember I said Kate was telling everybody to put hints and reminders and label those. Those are very important to have all these little things like this, so people can be reminded on a daily basis to do this. Here's what the inspector will come in and do a tour of your facility. The other day I asked Kate about books in here, because we got a lot of people complain about, hear people say inspectors will get you in trouble for having books. You have to clean each page and all that. Kate said that's not a big deal at all. They really don't look for that, so not to worry about that. But if you do have, she said get rid of all stuffed animals as well, because you can't have stuffed animals. But if you do have toys for children, especially, those are good to put in the well area, but you do need to have a regular cleaning schedule for those, at least daily, probably 2 or 3 times a day, the way kids are. And then talked about the exam room tables. Make sure that they're clean between each patient. Make sure that you know the wet time or the contact time for the Stericycle or whatever you're using to clean the exam room tables. Typically, it's going to be about 2 minutes for that, for you guys to do that. And don't put the paper on until the 2 minutes are up. Otherwise, it basically just soaks up all the germs into the paper that the patient is going to be setting on. So some of the things there. Facility tour, one of the things that they'll look at is these fire extinguishers. Once a month, you are supposed to charge that fire extinguisher. And how you charge it is you turn it upside down, you give it a good shake, and then you turn it back upright, and make sure that little yellow arrow is within the green. That means that fire extinguisher is charged and ready to put out a fire. Otherwise, sort of like a Coca-Cola. You know how you shake up a Coca-Cola and you open up the can and it starts spewing? If you don't shake it up, it doesn't spew. So you want to make sure that your fire extinguishers are done that, and somebody should be assigned to do that. You should also have a floor plan. Put it on about 4 or 5 different locations in the hallways. Some people put it on the back door of every exam room. You can do that. It's I don't know how great that is, but that is something that a lot of people do as well. And then make sure your exit signs have the light bulbs that are burning. Make sure that you do have lighted exit signs, because what Kate always talks about is if there's a fire and there's smoke and you can't see, how are you going to get out? If you have a lighted exit sign, you have a better chance of getting out. Here is the legal, the federal, state, and local laws there, your state laws as well. Make sure those are posted, and typically you'll have a room for the employees to go for employee break room, and that's where you'd want to put that as well. And let's see here. We'll talk about all this stuff here. I think we're running out of time, so I'm going to go quickly to the end. Let's see, medication storage. You guys will be getting all of this stuff later on, so I'm going to just squeeze through here. This is one thing that's pretty neat, is make sure all of your expired drugs, make sure you get rid of those. This is something called the West Virginia system, where it just shows you use different colored little labels, and you put on there depending on which month it is, and then you write what year they expire. So in the little purple section here, you'd put that, maybe that's for February, you'd put 20 on there, and so you would know that if you see one of these drugs February with the purple one, and it's a 20, you need to get rid of it. So really good way. A lot of people don't have samples anymore. They just have because you have to record anytime you give a drug sample to a patient. You have to put in the number. Let's see, what is it? The lot number for that particular drug, because if there's a drug recall, you have to get a hold of that patient and say, Mark, that drug we gave you, there's a drug recall, come in and give you a shot or whatever. So a lot of people have just gotten away from doing samples. The drug reps don't give away as many samples as they used to, and they'll just give vouchers for them. So probably not a bad idea to start doing away from that. Multi-use vials stored in patient areas. That is a big no-no. Controlled substances not adequately secured and not reconciled. You have to have a running inventory of any controlled substance, and it has to be double locked and keyed so that people can't get access to it. You can't just mass fill some shots and then set them aside and then give the shot later. That is just not a safe thing to do. So they'll write you up for that if they see that. And here's the rules for the refrigerators as well. So let's see here. I'm gonna go through all these real quick here. So because I think this is gonna be more important. Interpretive guidelines came out in January 2018. It's a 93 pager, and there's some weird things in there. These things are not legally binding. These are this guidance that you can see here. There's statutes that are definitely legally binding. Regulations are legally binding, but guidance, interpretive guidelines is not legally binding. And there's some weird things in this, and they're supposed to be any day now. At the meeting the other day, I think Kate was telling us that there's supposed to be a new interpretive guidelines come out in either June or July, where they updated this January 2018 one. And so that would be awesome if we get some new things here. One of the things that it talked about, here's some of the things that were weird. And the National Association of Rural Health Clinics took these 6 things to CMS and said, these doesn't make any sense to us. Number one was they said a physician's responsibility to review all records. And that didn't make sense to the NARHC, and certainly didn't make sense to me. The clinical policies must be developed by one physician, nurse practitioner, or PA outside the RHC. They basically was going to require you to hire these people outside the rural health clinic to develop your process and procedures, and they had to include a physician, nurse practitioner, or a PA. And that's just not the way things work either. And then you had to stock a snake antidote as well. These 3 things, CMS has sort of, I don't know what the word is, caved, or they're rethinking this, and they've told us that they are not going to enforce those things. Now, the antidote and the snake venom, depending on which inspector you get. I know I was in Kentucky the other day. Some of the people there in the audience were saying that the Kentucky folks were still making them buy snake venom. So if they're trying to make you do that, talk to us. We can talk to them and sort of get them on the right direction on that. A lot of times, if we just talk to them and say, well, the OA, and get them to the right person, Shante Carter from CMS in Baltimore can get them straight on that's not a requirement, even though it reads very clearly in the interpretive guidelines that it is. CMS would not agree to change. The survey team must include a registered nurse. That means when they do the survey, that registered nurse is going to go in to 2 or 3 visits, and they're going to be in the room. It's not going to be a HIPAA violation. So this is 5 is they must witness a visit. They're going to witness some visits. That's where they're going to write you up on the not washing your hands properly. And then it says here, the medical director must practice in the RHC. This is definitely not in the law. I know the law. The law changed July the 11th, 2014. It says the medical director doesn't ever have to set foot in a rural health clinic. Well, according to CMS, they in this guidance, the RHC medical director must see the minimum of 1 visit per year, which Again, makes absolutely no sense. So sometimes these regulations make no sense. So your medical director should see at least one visit per year. I know sometimes the nurse practitioner or PA will see the physician for something that's wrong with them, and that will be their one visit per year. And then why was a snake venom antidote required? The CMS person that wrote these regulations had never been to an RHC, went to one finally, and there was a snake in the parking lot and scared her half to death, which I certainly understand that. It would have scared me. Hopefully this wasn't the snake that was in the parking lot, but it scared her to death, and she put that in there. So now we don't have to have that. Some of the they are talking about requiring you to have an antidote, and especially with the opioid epidemic, Narcan is one that you can use. Probably, depending on where you get it, I've seen it anywhere from $200 a dose to $500 a dose to much less than snake venom, which will run I think it's $4,000 to $6,000 a dose, and you need 4 to 6 doses to really be effective. So also changing to the annual evaluation. When I talked to Kate the other day about this, she was like, well, you really don't have to change anything because they dropped the thing about where the physician has to review medical charts. So I may end up changing this slide based upon what Kate told me the other day, because at one point we would, on our annual evaluations, we would review 10 charts that are active, 5 charts that were closed, and that would be a part of it. We changed it because it said that a physician had to review charts, and we went back and started relying on the quarterly chart reviews, which you'll still have to continue doing, but we were relying on those for our annual evaluation. So we may change that one in the future. Let's see here. And okay, I'm on 50 minutes in. We got about 10 more minutes left in our time. I'll finish up with the slide section here, and then we'll have some time for questions. This was a recent survey. We had 3 clinics that were surveyed, and just to see the sort of things that you can look for, we had to do a in-service with them to correct these issues. We did it via tabletop, so we had 3 different clinics that were written up. The first one here, and remember Kate said that she'd seen 5 of them where the emergency preparedness was not done. We see this all the time. Here lately, we're getting phone calls of people that are getting condition level deficiencies because of risk assessment, and the emergency preparedness stuff is over 1 year old. So all 3 of this particular client's clinics had that deficiency. So we had to go do risk assessments and update emergency preparedness policy and procedure manuals for all 3 of those. And this one here, and 3 of them did not do an automated defibrillator inspection log. So they wrote that up on all 3 of those. So if you're not doing your automated external defibrillator with a log every month or every week or every day, I mean, I've seen it all over the place on people. What you should use is what the manufacturer's guidelines. So read your manufacturer's guidelines. If it says it should be tested daily, weekly, monthly, then that's what you should use. Charting of injection sites in the medical records. Again, with the opioid epidemic, it's very important that you put in a medical record where you're injecting these patients if you're giving them shots, because a lot of times it becomes a legal issue of was that injection shot given by the doctor legitimately, or is this person on opioids or on some type of drugs, and they're shooting themselves up. So that becomes a legal question. So you want to make sure you do that. Consent to treat. They found it in 2 of the 3 clinics there where consent to treat were not up to date. And in hand washing, they only found it in 1 of the 3, but that one is a big one. We're seeing that in a lot of inspections lately. And then expired drugs. This clinic had a ton of expired drugs. So make sure you go through and do your expired drugs. Here's the hand washing video that we ended up watching for everybody for those 3 clinics because of the hand washing deal. Resources. Here's some of the things that you can go to see. Let me see here, and I'm not going to go through these in any type of, just speed through them just so you see that they're there. There's an emergency preparedness training module that you can go through, and an RHC training module. That's about 25 hours. So if you guys want to become RHC inspection experts, go through that module. I haven't been through the whole thing, but it's pretty good. And then this is a new site that you can go to. It's only been added within the last year, where you can actually see all the deficiencies that the feds have written up over the last year or so. So it's pretty neat as far as knowing what they're looking for. And so here's just what this report looks like. So it'll tell you all the different J tags or E tags that they have written up over the last year or so. Here's something from Idaho. That's some really great documents as well. And of course, new emergency preparedness stuff here. We'll go through that very quickly. I do want to go to our website on emergency preparedness, and you can see there, if you haven't done all your emergency preparedness stuff, all you have to do is go to our website at ruralhealthclinic.com, emergency preparedness, and you will be able to find just about everything on emergency preparedness. And then resources, and all this stuff is free. There's nothing on our website that costs any money whatsoever. Certification materials, this is where we have a ton of information on becoming a rural health clinic. We will post this webinar on there after we get it on there as well. After it's been recorded, it will be on YouTube as well. So if you miss some of it, or if I talk too fast, you can do that as well. Let's see here. But just go into resources here. You'll find tons of documents there. Cost reporting, annual valuations, RHC billing, all of our update materials are on there as well. So let's open it up for questions at this point here. Let's see. Danny, can you help me? Are there any questions in the question box?
You got one.
Okay.
It's in regards to the chart reviews. And okay. Debbie asked, can we use the state nurse practitioner 10% for the chart review?
The answer I get to people on that one is no. They want to be a completely separate sort of chart review. They want to keep it separate from your medical records. Typically, we have forms that you guys can use to do those. So we want to do that medical director review in addition to the 10% required review. If you absolutely, your medical director doesn't want to do that, then what I would do is get together a listing on a separate piece of paper, put it in a separate folder, and then write down the chart numbers of the 10 that they reviewed, or 15 that they reviewed each quarter, and put that on a listing so you can give that to the state inspector. Because if you tell them it's a part of the 10% review, they typically won't accept that. They want to have the physician to have those reviews separately from the medical record. Okay. All right. And let's see here. Do we have anybody, attendees? Stacy, was that? Do we have any hands up? Anybody have any questions they want to? I can open your line if you want that. Did Stacy have a question? Okay. Got Christy, Debbie, Stacy. Oh, okay. Congratulations, Danny. Yes. Can we use the 10%? No, but thank you. Okay, perfect. Okay, anybody? I'm gonna give you just a couple more seconds here. Oh, Anita's. Let me see. Hi, Anita. Can you hear me?
Hi, I can. Can you hear me?
I can hear you great.
My question earlier, you had talked about a site where you could go to check and make sure that your providers were Medicare approved, right? Was that so?
It's basically not Medicare approved, but it's Medicare does not. They haven't done anything wrong. That's called the Office Inspector General. It's in your policy procedure manual. There should be a policy that states every year we will do that.
Okay.
But I will, whenever I shoot my email out to everybody with these documents on it, I'll put that website on there for you so you guys can look those up.
And we have to do that even though we're pediatrics and are not seeing adults and not billing Medicare?
They're going to make you do that because what happens is when somebody's excluded, from the Medicare program. They're going to exclude them from the Medicaid program. And there's reasons. There's other reasons besides just Medicare fraud that they would not let anybody see these patients. It could be horrible things that they do to people. So that's one of the reasons. They're going to make you do it, unfortunately.
Okay.
All right, Nina, we will see you. I'm going to be up there in a couple of weeks, so we'll be in Ohio to see you guys soon. So
Okay.
All right. Thank you. All right, I'm going to close out Anita's line. And
Mark, we got another question that came through.
Okay, go ahead.
As far as the medical director seeing patients, can he see them in the nursing home?
Yes, that would be perfectly fine. If he's doing them in the nursing home, that should work just fine. Okay. Let's go through here. Any other? Okay, Krista took her hand down. Any other questions before we? Okay. All right. Well, thank you all for your attention on this Tuesday afternoon. We will get the questions answered. We'll get some material together, send it out to you guys via email, and thank you all very much for your attention today. This session has been recorded and will be on YouTube eventually. So thank you all very much.